Welcome to this explainer. Today, we're exploring one of the absolute most fascinating aspects of human anatomy, the cardiovascular electrical system. Think of the human heart as this beautifully engineered, flawlessly synchronized electrical grid. Billions of times over an average lifespan, it generates a spark, sends it down a very precise pathway, and pumps life-giving blood to the rest of your body. But, just like any complex electrical grid, sometimes the wiring develops a glitch. Sometimes a signal gets caught in a loop, and when that happens, the heart goes into complete overdrive.
Okay, let's dive right into this. Imagine you're just sitting at your desk, perfectly calm, maybe reading a book, and out of nowhere, your chest starts pounding. Your heart rate shoots up to 160, maybe even 200 beats per minute. You might even feel this really strange fluttering in your neck. Well, this isn't anxiety, it's an actual structural electrical anomaly. The normal rhythm of life has suddenly been hijacked by a rogue electrical circuit. So today, we're going to break down exactly why this happens, how we identify the specific type of short circuit, and, incredibly, how we can literally hit the reset button to fix it.
Here's our roadmap for this explainer. 1. Normal heart electrical wiring. 2. The short circuit, PSVT. 3. AV-NRT, the nodal loop. 4. WPW and accessory pathways. And 5. Hitting the reset button.
Section 1, Normal Heart Electrical Wiring, the baseline grid. Now, to understand the glitches, we first have to understand this baseline grid.
So, let's take a calm, steady look at how a normal resting heartbeat is generated. Every normal heartbeat kicks off in the sinoatrial, or SA node, which is up there in the right atrium. The SA node has this amazing property called automaticity. It basically acts as the heart's natural pacemaker, reliably firing off regular electrical impulses. This impulse travels across the atria, causing them to contract, and then it reaches an absolutely crucial checkpoint, the atrioventricular, or AV node. In a normal heart, the AV node is the only electrical connection between the top chambers and the bottom chambers. And crucially, the AV node acts like a physiological speed bump. It deliberately slows the electrical impulse down just a fraction. This tiny delay allows the ventricles time to fill up with blood before the signal is passed down to the fast-conducting Purkinje fibers, which then rapidly squeeze the ventricles to pump the blood out. It's really a masterpiece of timing.
Section 2, the short circuit, PSVT. But what if that masterpiece gets interrupted? What if the signal doesn't just travel from top to bottom, but instead gets trapped and starts racing in circles?
Well, this brings us to a family of arrhythmias known as PSVT, or Paroxysmal Supraventricular Tachycardia. Medical terms can sound pretty intimidating, for sure, but let's break this down into its simple, understandable parts. Paroxysmal just means sudden. These episodes start and stop abruptly, literally like flipping a light switch. Supraventricular tells us the origin of the problem. It's happening above the ventricles, specifically involving the atria or the AV node itself. And tachycardia simply means a fast heart rate, strictly defined as over 100 beats per minute, though in PSVT it's often way faster than that.
Section 3. AV-NRT, the nodal loop. This is the single most common form of PSVT, making up about 60% of cases referred for catheter ablation. It's called AV nodal reentry tachycardia.
Now, what's really interesting here is that in AV-NRT, the glitch happens right inside the AV node area. Instead of having a single pathway down, some people actually have multiple pathways for conduction into the AV node, typically a fast pathway and a slow pathway. And because these pathways recover their ability to conduct electricity at slightly different speeds, a perfectly timed premature heartbeat can send a signal down the slow pathway and then straight back up the fast pathway over and over again.
This creates what computer programmers would call an infinite loop. The electrical impulse just circles continuously inside the AV node, firing signals up to the atria and down to the ventricles simultaneously. And because the atria and ventricles are contracting at the exact same time, the atria end up squeezing against closed valves. This actually forces blood backward up into the neck veins, literally giving you a pounding pulse in your throat. We call this sensation a Canon A wave. It's a hallmark clinical sign of this very specific anatomical loop.
Section 4. WPW and accessory pathways, the secret back alley wire. So while AV-NRT is an anomaly right inside the AV node itself, our next structural glitch involves a completely separate, secret back alley wire that bypasses that normal checkpoint altogether. This is the defining feature of Wolff-Parkinson-White, or WPW syndrome. Get this, about 1 in every 1,500 to 2,000 people are born with an accessory pathway.
During fetal development, the fibrous rings that are supposed to completely electrically insulate the top chambers from the bottom chambers fail to partition perfectly. So this leaves a tiny strand of conductive tissue, a secret wire, connecting the atrium directly to the ventricle. Because this wire doesn't have the speed bump properties of the AV node, the electrical signal gets to the ventricle way too early. On an ECG, this creates a really distinct slurred pattern called a delta wave, indicating that the ventricle is being pre-excited.
And this brilliantly illustrates the difference between our two main types of short circuits. In AV-NRT, which we just looked at, the re-entry loop is trapped entirely inside the AV node. But with WPW, patients can develop a tachycardia known as AVRT, atrioventricular reciprocating tachycardia. In the most common form of AVRT, the electrical signal goes down the normal AV node path, but then races back up to the atria via that outside accessory pathway, creating a massive, heart-wide electrical loop rather than a localized one.
Section 5. Hitting the reset button, acute management. So, you have a patient whose heart is stuck in one of these infinite electrical loops, racing at 180 beats per minute. How do medical professionals actually regain control over the heart rate and terminate these tachycardias?
Well, the crucial point is that because both AV-NRT and most forms of AVRT rely on the AV node to sustain their electrical loops, we just need to temporarily block the AV node to break the circuit. There's a clear escalating ladder of acute management to achieve this. We start with physical techniques called vagal maneuvers. If those fail, we move to a powerful chemical blocker called adenosine, and in rare, really unstable emergencies where blood pressure plummets, we use direct current cardioversion, basically an electrical shock to reset the whole system. Let's look closely at those first two steps.
It's fascinating how this builds upon our understanding of the nervous system. The heart is heavily innervated by the vagus nerve, which basically acts as the body's natural brake pedal. We can physically stimulate this nerve to slow down the AV node. The most common method is the Valsalva maneuver, where the patient bears down as if blowing hard into a blocked syringe. This increases pressure in the chest and triggers a vagal response. Another technique is carotid sinus massage, applying firm pressure to the neck. Though, quick side note, this must be done very cautiously to avoid dislodging any hidden plaque in the artery. Finally, there's the diver's reflex, abruptly submerging the patient's face in ice-cold water. This triggers an ancient hardwired survival reflex that sharply spikes vagal tone and often snaps the heart right out of its loop. Pretty wild, right?
But if those physical hacks don't work, we reach for the medication adenosine. This drug is practically miraculous in its speed and efficiency. Administered as a rapid 6 or 12 milligram intravenous dose, adenosine acts as a fast-acting chemical circuit breaker. For a few terrifying but highly effective seconds, it creates a complete block at the AV node. The ECG actually goes totally flat for a moment as the infinite loop is shattered. Then, the SA node, remember that natural pacemaker we talked about at the very beginning? It wakes back up, reasserts its dominance, and restarts the heart in a perfectly normal, calm rhythm.
So, we've journeyed from the normal electrical pathways of the heart to the sudden, chaotic loops of PSVT. We've seen how microscopic anatomical glitches, like a dual pathway in the AV node or a hidden accessory wire, can cause the heart to just race out of control. And we've learned how medical science uses the body's own reflexes and potent molecules like adenosine to break the circuit and restore order. With billions of beats in a lifetime, isn't it incredible how a simple held breath or a single fast-acting molecule can completely reset the rhythm of life? Thank you so much for joining me on this explainer, and keep marveling at the incredible machine that is the human body.